Hello and welcome to this panel discussion on whether the EU is living up to its big stated ambitions on global health. Global health is no longer the issue relegated to corridors in Geneva, and I think if there's one thing COVID-19 revealed to everyone, from industry to policymakers, is that health crises need collective action, whether that's on R&D, procurement, or health system strengthening. And today we're going to be looking at what the EU is doing to ensure that countries beyond its borders are as well prepared as it is. Welcome to the on-site audience and those of you online joining us. A reminder that you can ask questions using the Swapcard app, and please also tweet using the hashtag Politico Healthcare. In person with me today, on the far left, my far left, we have Martin Seychelles, Deputy Director General of DG INPA. We have Inma Vazquez, representative to the European Union for Medicines Sans Frontières. And joining us online, we have FIFA Ar-Rehman, civil society representative for the ACT Accelerator on COVID-19 response, and Gail E. Smith, Chief Executive Officer of ONE. Thank you, everyone, for joining us. I'm going to kick off straight away with a question on the funding, and it's been something that I've been thinking about a lot recently. You know, we've had a lot of replenishments for CEPI, for the Global Fund, the recent polio replenishment, and with all of these, they haven't met their stated goals. You know, they've been quite big. They've raised quite a lot of funding, but they haven't met their goals. And in my mind, I sort of saw, a couple of problems. The funding asks obviously getting bigger. There's more varied asks, and we have, less money globally to spend on global health. Martin, when you see countries pledging, I'm wondering if you're seeing a pattern of less money available, or is it just that there's just too many and too high, asks?
Yes, thank you. Well, first of all, it's a difficult situation. I think we all realize that budgets everywhere are under enormous pressure as crises multiply and these crises reinforce each other, unfortunately. Having said that, I think there is a growing awareness, and I think this has been a positive effect of what has happened in COVID, that health is not just a necessary investment, it's a precondition for building a more stable world. I think this is definitely slowly but surely sinking in, and that there are clear signs of that. Now, the big risk I see is that, first of all, it's important to make sure that global health remains on the political radar for a long time. It's not enough to act on the spur of the moment. And also, we need to avoid, because there is a big problem in the global health architecture of fragmentation. And there is a risk that funding just goes from one pot to another and does not really mean additional funding. I'll just give one quick example. Some years ago, the world had to react to the Ebola outbreak in West Africa. And the vaccine was developed against the Zaire strain of Ebola. Now we have an outbreak of the Sudan strain in Uganda, and there is no vaccine yet, even though it should be certainly scientifically possible to have a vaccine. So why? Because the world's attention shifted to other things, COVID and other things. And that's my biggest concern. But I think there is a growing realization of the central importance of global health. And also, I think there is also a growing attention to the fact that we also need better coordination of all these instruments. So it's really important, and this is the only way indeed to make all this work, is to make sure that these different instruments are not competing against each other for scarce resources, but are actually working in synergy and reinforcing each other. And I think, there are important lessons learned also from the pandemic, that, as the previous speaker mentioned so eloquently, it's not just about health. We cannot just find medical or even just scientific solutions. Many of these challenges require also action in the economic, social area. They require also integration and cooperation with other sectors as well. The management of health crises is not just for health experts. And indeed, sometimes not even primarily for health experts. You need to keep economies afloat. You need to keep people's attention on addressing the issue. You need to make sure you have the support of society. And so I think there is a need to ensure a much better coordination. One of the key lessons learned, and certainly there are many lessons to be learned from COVID and recent health crises, but this is certainly one of them.
Beef, I wanted to ask you about that. Are these different mechanisms competing with one another? And we've seen a lot of new mechanisms come up in the past year or so. And is that something that you are worried about, that there might be like competition? Well, it seems like there is competition because there's less funding being given to them, but I'm wondering if that's something that you agree with.
I think, so the issue of competition, I definitely think I agree with this previous speaker that there is fragmentation, but I'm less worried about competition than I am about ineffective solutions to future pandemics, and I think, or non-complementary work. And there are, fundamental issues with the global health architecture in that it just doesn't leverage LMIC expertise sufficiently. And that really boils down to, how we think, who dominates the discussions, and this translates directly into delivery of commodities. So my concern, I suppose, is more about the global health architecture and how it motivates itself in the next pandemic.
Thanks, Bifa. Gail, I'm interested in your perspective because you obviously are at one now, but you worked obviously with the U.S. administration during the pandemic, and you have that insight, and I'm wondering, is there just the pot is too small, and there's just not enough funding for global health. There's inflation, there's soaring gas prices, there's a lot of other competing interests, and I'm wondering if there's just not enough money to go around, really.
Thanks very much. Look, I think we've got a bigger problem, which is the way that we look at financing both pandemic response, but also prevention and preparedness over the long term. So problem number one is that this is mainly financed out of government's aid or ODA budgets. And those budgets are being tapped for a series of crises now, as Martin suggested. But the top line is not being increased. So that's problem number one. Donors have not made the decision to raise the overall level of ODA. Second, the great irony here is that the world, the EU, the United States, everybody spent trillions of dollars responding to and managing the aftershocks from this pandemic. Yet when it comes to preparing to prevent the next one, we're kind of coming to the conclusion that there isn't enough money. There is enough money if the right choices are made. And I think the danger is what Martin suggested. I worked on Ebola, and in the immediate aftermath of that, we in the Obama administration launched a whole initiative with others on building the capacity of other countries to prevent, detect, and respond. That got funding and political support for perhaps a year, 18 months, and then that waned because, as Martin suggests, everybody moved on to something else. If you think about the fact that this pandemic is not over, we've seen monkeypox, we've got a serious outbreak of Ebola in Uganda, and polio cases are being recorded in Europe, the United States, and Israel. That suggests that we need to spend less money now to prevent having to spend much more money in a not very distant time to manage the next round. So I think part of our challenge, and one of the things we're focused on at one, is trying to turn this upside down a little bit. And rather than just urge increases in aid, which we certainly will do, we're trying to persuade governments that they got to think about financing this from a much, much different perspective.
Thanks, Gail. And in my, we spoke about, there's a lot of focus on pandemic preparedness and sort of these emerging, monkeypox. We put a lot of money into that, and then, obviously before that, COVID-19. But there's a lot of illnesses that have been, plaguing many countries for a very long time, and I'm wondering if you're seeing sort of less focus on them, less focus on cholera, less focus on rising cases of malaria, TB. We just had the global TB report yesterday, which was not very good news, and I'm wondering if you're seeing sort of less attention focused on illnesses that have been with us for a very long time.
Yes, indeed. And I am going to take what my colleague was saying just before. indeed, our teams on the ground, MSF teams on the ground, are busy and overwhelmed by diseases that don't have the world's attention. But I am going to make a nuance. It's not the world's attention. It's the global north part of the world attention. Because there is attention on the ground when we are working, and this is impacting people's lives. So some of these diseases have been mentioned already, but I am going to mention, for example, cholera. So today there are 30 countries in the world that have declared already cholera outbreaks, and there are some countries that, and unusual countries, some of them, that are facing very big cholera outbreaks. This is Syria, Lebanon, there is Haiti, there is also Malawi, and now Kenya, for example. So what happens with cholera, there are two producers of cholera vaccines. The cholera vaccine is used, is used for prevention of cholera, but is also used during the outbreaks. So there are two producers. One of them has already announced that in 2023 they will stop producing this vaccine, and this despite the WHO recommendations not to do so. So what has happened is that today the international body, the ICG, for those who know that regulates the use of vaccines in emergency, has already announced a temporary suspension of the standard protocol of 2 doses of cholera vaccine during the outbreak. So there's going to be 1 dose administered. So this is one. So the Ebola in Uganda has already been mentioned. So for this one, there is no vaccine and there is no treatment because it's the Sudan strain. But again, I would like to remind that when there was the outbreak in West Africa in the past, when research came, when the means came, was when the Ebola reached the rich countries. So it was not before, because we were for years dealing with that Ebola with no one intervening. But I am going to talk about other disease that is impacting our daily, and we are extremely worried about that, is malnutrition. So we have at this moment in several countries of the world, in Africa, but also in Yemen and in Afghanistan, which are with emergency levels of malnutrition in the programs, and we are overwhelmed. And just to give the example, just by August 2022, we had already reached more than 50% of the number of patients that we have reached in the entire 2021 year. And when we talk about malnutrition, we think about food security or food insecurity, but it's also health. And for example, one thing, or one of the impacts of COVID was that there was a disruption of measles vaccination. And measles is a disease that is immediately or very often associated to malnutrition. So this is another thing. But then, and then we have the ongoing HIV/AIDS, malaria, and TB pandemics. So and you have seen what has happened with the global fund replenishment. But I can just give some very short data of an assessment that we did, MSF, in 7 countries this year with the programs that we are running. And we have seen decrease in tests of HIV, decrease on treatment initiation, important ones, 50% drop, for example, in Uganda. Then we have seen a very large number of cases that come to our facilities with advanced HIV disease, for example. Then we are seeing also a drop in TB, and this was also mentioned yesterday, but also malaria. Malaria is a great concern, and malaria is a great killer. And we have seen also a drop in coverage of malaria treatment, and there is a trend to have more malaria in the world. So I leave it for the...
On that depressing note, but one of the sort of immediate things that comes to mind when you're speaking about that is that there's sort of less focus on health system strengthening and possibly quite a lot more on these, innovative, shiny new tools like vaccines for new diseases. And FIFA, I was wondering if that's something in your role at ACT Accelerator you've seen, and you've seen sort of wondering what you've seen on the focus or lack of focus on health system strengthening, and maybe you could tie it into to what Inma was saying about the pretty dire state of rising, many rising cases of different diseases.
Yeah, absolutely. So throughout the ACT Accelerator, the ACT Accelerator actually has a health systems connector in it. And a lot of people don't know about this because of the extensive focus on the COVAX. And at the start, in 2020, one of the things that we wanted was to see community health workers invested in and other sort of more traditional health systems issues. And we see a real disconnect between what LMICs want and what HICs want, right? And whether this is the ACT Accelerator or the fifth or whatever initiative that's coming. The health systems connector was quite a neglected connector or pillar within the ACT Accelerator. There just wasn't funding for it. There wasn't donor interest. It was one of the pillars that sat the least, and it did a lot of conversations behind closed doors. And there definitely is a real disconnect between what LMICs are prioritizing and what HICs want to fund. And, we saw this illustrated so well in the Biden Health Summit, for example, and it was so noticeable. A number of people tweeted about it, where every time an LMIC took the floor, it was about health systems, health workforce, infrastructure. And every time a HIC took the floor, it was about surveillance and commodities. And I know you're coming to surveillance, so, we can talk about that later. But I came away from that meeting with sort of a clear sense that HICs were not listening to the Global South, and surveillance kind of became the biggest priority, because HICs want to be able to react quickly and protect their people and economies. And while surveillance is obviously quite important, it became quite clear to me there's a disconnect between what the LMICs want and what the HICs are providing at this minute because of what's sexy and what isn't.
And Gail, how do we make health system strengthening sexy?
Well, I will tell you, I've thought about that a lot as I've been in government, but when I'm not serving in government, I tend to be an activist, and it's not the easiest thing to campaign around. But I think FIFA makes a really, really important observation, and it ties back to what my colleague from MSF said, which is on the ground in these countries, these are priorities. Health system strengthening is a priority. In donor countries, there is a tendency to look at these as humanitarian crises, right? And so we've got the low-income countries and middle-income countries focused on what is a long game. How do you systemically and structurally change a set of circumstances that leave them more vulnerable to these kinds of shocks? On the donor side, this is the crisis of the day, so how do we respond? So I think that's a really important point, and one that we've really got to work on. I think on health system strengthening, actually the pandemic gives us a bit of an opportunity to explain even what that is, and to make the case, and I think Africa has been particularly strong on this, that unless and until there is greater capacity everywhere in the world, those countries are not just going to be more vulnerable, but the argument to donors is they're going to be more vulnerable as well. I think we can show lots of examples where, despite the gaps, the health systems that have been strengthened over the years delivered in this pandemic, even in some very poor countries. So I think we can also put that argument out there. But I think the best argument, and that's if you're trying to persuade people who aren't necessarily those of us on this panel, but those who might not see this the way all of us do, is that by strengthening those health systems, we reduce the scale of the threats posed by these viruses. It's a very practical argument. It's a pragmatic argument. I've been in government, principled arguments work, but very pragmatic arguments are also very effective.
Thanks, Gail. Martin, I want you to come in on the health system strengthening, and perhaps to bring in, to ask you the question whether the EU is listening, and then also maybe to bring in the global health strategy, because as I understand from the few things that have been said about it, that might be something that is being focused on in it.
Yes, thank you indeed. First of all, it would be a mistake to reduce global health to just talking about pandemics. First of all, global health is much bigger. Pandemics, in a way, are disruptors of normality, but even the normality is really of great concern. I just point out that even at the height of the pandemic, in many parts of the world, the deaths from COVID were eclipsed by deaths from other diseases, other infectious diseases, but also non-communicable diseases. Even in Europe and North America, many of the deaths caused by COVID were because of poorly diagnosed or poorly managed or undiagnosed chronic conditions. And health system strengthening is key. And this is going to be definitely one of the priorities in the global health strategy. I would argue that indeed pandemics are caused by health systems that are not sufficiently strong. Outbreaks of disease are a natural phenomenon, but pandemics are preventable. And the health systems, and especially the primary healthcare element, is the first line of defense. This is where surveillance happens. This is where first interventions can happen. This is where you can vaccinate people. This is where you can treat people and avoid that the disease gets worse. Now, if these lines of defense are not there or are weak, a pathogen will break through and develop into a pandemic. So I think in the global health strategy, of course, we will not try to write the encyclopedia of global health. This is not the aim to try and cover everything, but to identify a few very important areas where we believe that the European Union can also make a difference. And without divulging too many details, because this is still work underway.
Can divulge.
but it's clear we have to look at things like workforce. We have to look at things at how we also use technology, not for the sake of technology, but to support the workforce. There are lots of things that can be done today, many interventions that can be pushed to the primary healthcare sector in a much more efficient way. We can have much more real-time data of what's happening. We can support frontline health workers in a much better way. Just if you think, for example, what the imaging revolution or diagnostics, take something very basic, the management of diabetes. In our part of the world, this is very easy. It's still, of course, a challenge for the patients concerned, but imagine where you don't have diagnostics, where you have problems with insulin supply, no refrigeration, it becomes a very, very difficult, if impossible task. So I'm talking here about a very common disease, not an infectious disease, but one which obviously then makes people more vulnerable to a whole host of infectious diseases. So the strengthening of health systems is absolutely key, because only on top of health systems can then you build all the other things everyone is talking about, the surveillance capacity, the vaccination campaigns, If the health system is not there, how do you do this? We're seeing this right now in the countries in the world where the rate of vaccination for COVID is still very low, are countries where the health systems are non-existent or very, very weak. They simply cannot get the vaccines from the tarmac to people because there aren't the means available. So this is definitely going to be one of the priorities, of course, to identify some areas where we think action can happen. And indeed, this means you have to work with individual countries, because obviously this is very much linked to the national health strategies of countries, but countries should be able to count on regional and global networks for support. There is a capacity problem, and health systems should not be left alone to deal with complex issues. They should be able to tap expertise, advice on a regional and global basis. And indeed, that's a big part of what the global health strategy will be talking about.
In Mo, you were writing the headline for what the global health strategy should include. What do you think really needs to be top of mind in Martin and his colleagues' minds as they look at this?
Yes. Indeed, I am going to take also some of the interventions and to complement. So for us, global health, the first of all is that it has to be a people and needs-based approach. But I am going to be more specific because you are talking about health systems. And I want to go a layer beyond, which is community approaches, community-based approaches, so communities for health. So, and we do have the experience on how important it is beyond the health system to resource, equip, and train these communities, which are essential in emergencies. And we have experience, for example, we experienced in the Ebola outbreak, in the latest Ebola outbreak in DRC, well, it was not the latest, but the before, in a conflict area, in the kibbutz, how the lack of acceptance of the communities and the lack of work with the communities was a mistake that we all did, and that it created a serious obstacle to be able to respond, because they were not accepting, they didn't want, they were afraid of the response. So this is very important, but also we have good examples. For example, in Central African Republic, when the conflict started, that with the community approach, we managed to continue HIV/AIDS treatment, so that's very important. So community approaches. But then one element that has not been mentioned is is the out-of-pocket expenditure, which is because you were referring to how important it is to have primary health care, a strong health system. So the out-of-pocket expenditure in the poorer countries, for the most vulnerable populations, is a serious problem. And we are going backwards. Again, I'm sorry to be negative, but we are seeing more user fees being used for example, around the HIV programs. But we are also seeing that in countries where, in theory, people don't have to pay to use the public health system for the key essential diseases, we are not talking about sophisticated, just for malaria, for everything, de facto, they are being asked to pay. Why? Because the workforce doesn't receive salaries, because there are no supplies. So when they arrive, they say, no, but you have to pay. And for example, in a country like Yemen, where there is a conflict, we have MSF hospitals, the emergency rooms are full of people that are coming that should not be in an emergency room, but they come long distances because they don't have primary health care in their villages, or they cannot afford it, because there is, but they cannot afford. So they make a long trip, dangerous one, just to come to us. And then one thing in particular for the EU, I want just very quickly to mention some countries, because yes, it's important to have health systems, it's important, but the reality on the ground is that there is less money available, both humanitarian and development, for health. That's what we are seeing. South Sudan, one example, for example, with the UK funding cuts, there are now 200 primary healthcare facilities that have been impacted, 8 main hospitals in the hospital, and 144 nutrition centers that are disrupted completely, and no one has so far properly stepped up. Central African Republic, completely abandoned. Some areas of Nigeria, I mean, I could go on and on. So yes, health systems are very important, but the reality on the ground is that the resources are not enough.
Thanks, Ima. You mentioned the UK funding cut, and we have a question here from Nico Keppens, and they're asking about how to avoid that donors promise something that they can't meet, or they promise something and then they pull out later. And I'm also wanted to sort of add to their question, because we've seen when administrations change, there might have been a promise previously to fund something, and then the next year that promise dissipates. I'm wondering, Gail, if that's something that you could elaborate. How do you prevent that? Because it's always pledges, but I suppose what really matters is actually the money in the bank.
Yeah, I think that's exactly right. I think there are a few things that we can do about that, but I think we can't understate the significance of what was just referenced with the across-the-board major cuts in aid from the UK. Because while, as I said earlier, aid budgets are fairly flat, although the demand is greater than it's ever been, basically taking the UK out of the picture as a major donor has had the very real effects that we just heard about from MSF. I think there are a couple things. Look, the transparency of aid pledges and delivery has been something that I think has been a priority in the NGO and advocacy community for a long time, both in donor capitals but on the ground. And I think the more of that the more monitoring that is done, the more data that is captured, the more visibility that is given to whether a pledge translates into actual delivery is absolutely key. It's a long play, but I can say, having worked inside a government and from the outside, it is the most effective argument to making sure those pledges are acted upon, and in making sure that donors don't double count, which often happens. There'll be a big conference on an issue, and donors will announce big aid allocations that they've actually announced 3 times before. But I think the second question is a political one, and I think there we're at some risk. We've mentioned the UK stepping back. You've talked about changes in administration. We've certainly seen in this country how big a swing there is from one party to another on some of these issues. And what that really requires is an external constituency and advocacy for funding of these issues, for global health beyond and including pandemics, and one that, and this is the hard part, where we've got to build the political support from across the political spectrum. In the US, and this is a stunning thing to me, one of the few places where there's actually agreement between the two political parties is on things like funding the Global Fund. The money that was authorized by Congress for the pandemic response came from both parties. That's because there's been a years-long effort by external groups like ours to knit together a constituency of both political parties to say this is something we've got to keep doing. But if we lose that and this becomes a political football even more than it has been in some instances, then I think we're in real trouble.
Thanks, Gail. I want to shift to something FIFA was mentioning earlier about surveillance, and there's been a lot of discussions about, what we require on countries, whether we require them to share the genetic data that they find during the surveillance, and whether there's sort of a reciprocal benefit for these countries. And there's a lot of discussion with industries having one opinion, developing countries saying something different. And FIFA, I'm wondering how you incentivize this, and what's the incentive for countries to increase surveillance and to share their findings of surveillance, and how do we reward that, and what does that reward maybe look like?
So I don't know if I'm the right person to answer this question, because I'm trying to balance the conversation. There's an overemphasis on surveillance right now versus investment in community health workers and things like that. So I'm going to give you a brief answer and let somebody else answer that. But I am going to say that there is certainly an overemphasis in surveillance, contrary to what LMICs are discussing. And I want to bring up the fact that, throughout the pandemic, the folks that were really pushing on surveillance, all these lab experts who are, of course, valued in many ways, were not necessarily the best voices for access in terms of self-tests, because there's there was so much PCR fundamentalism, and we had self-tests all over the global north. But there was a lot of conversations about, but what if we can't, we can't report? What, if we give self-tests to the global south, how are we going to have surveillance? And you're like, look, we need to have a human rights lens on this situation here. Surveillance is important, but the idea that you're using surveillance to prevent access to self-tests for LMICs is a problem. Why do you get the right to health in terms of knowing what your status is, but not somebody in the global south who needs self-tests? So my role is less on encouraging surveillance, because I don't need to do that. That's currently heavily being emphasized and by both money and rhetoric, right? And it is important, but it is completely overtaking the situation, and it is diverting attention away from the very real human right to health and access to rapid tests and deployment of rapid tests by community health workers that we're trying to push through.
Gail or Inma, would you like to come in on that? On the sort of...
Yeah. Sure. I think, once again, FIFA, you're absolutely right that, and I think this focus on surveillance gets to something mentioned earlier in the context of the EU strategy, that technology is important, but for not just for technology's sake. And I think there's a tendency of many in this system to kind of look at, oh, surveillance is the thing that will protect us in the future. And it's a feature, but as FIFA says, it's getting way more emphasis than some of the other features that are equally, if not more potent. I would say on the incentives to share data, it's got to go both ways. And, look, there are a number of cases where the genetic sequencing that allowed the world to understand some of the mutations of the coronavirus came from South Africa and were widely shared. And then what happened to South Africa? Well, suddenly they faced travel restrictions because they'd identified an Omicron variant. That's a problem. But the challenge we have, and it gets to something I think colleagues have referred to, there's a missing fundamental equity in the entire approach to global health or global health and extremis, i.e. pandemics. And unless and until we get to the point where everyone agrees that they're going to put data on the table, including the data that informs some of the medical countermeasures like vaccines, the expectation that data will flow one way and not the other isn't going to work. It's not going to be realized. There's got to be an understanding that everybody has an obligation and an interest in putting that data on the table, and that everyone will comply.
I'm going to pivot slightly to sort of looking at global vaccines procurement, or just more broadly, global sort of drug procurement. And obviously we have COVAX, and I'm wondering, Inma, if you think that that's something that you would like to see kept in place in some form, or the structure vaguely kept in place, so that when there's another health crisis, we have something sort of ready to go.
Yes. Indeed, I wanted to emphasize one of the tools within COVAX during the COVID pandemic, so I go to this to afterwards answer. One of the tools that didn't work was the humanitarian buffer. So the humanitarian buffer within COVAX was supposed to be the one that will allow humanitarian organizations to have access to these vaccines to be used in conflicts or for areas where populations were left out from the government response. So MSF, that is a big organization with capacity and means, we put a team of lawyers to do the application for the humanitarian buffer, and we failed. And this was for northwest Syria. So why did we fail? First, because this was the humanitarian mechanism. So first, because there was the process itself was extremely cumbersome. Just 6 weeks just to have the application accepted, and then months of negotiations. Second, because there was a total lack of transparency on the information, and we couldn't get information on contracts that were essential for us to understand the risks that we were assuming. But the third and more important one was the transfer of liability, financial and legal liability risk, to us as an organization. So we were being asked to renounce, to give up to legal avenues, and also to potentially do indemnification for the drugs before we were getting them, so before they were on our hands. And why was this? It's because the Global North, again, exempted the pharmaceutical companies to various degrees from the legal and financial liability from the safety of the product. So this is something that is the first thing that needs to be solved if we want to have humanitarian tools in next pandemics. So there needs to be a tool that is flexible. There needs to be a contingency stockpiling, focusing on the most vulnerable, and the issue of liability of the products needs to be solved.
Thanks, Inma. Martin, I'm interested because obviously the EU has HERA, which is, in many cases, ensuring that mechanism is available for the EU, so that the EU is really ready to go at the next health crisis and ready to purchase the drugs, the vaccines, whatever is needed. And I'm wondering if you think then there should be something that, like COVAX, if that's something that you think would be beneficial for the rest of the world to be able to also use.
Yes, indeed. Our European experience has certainly been that grouping together for procurement is very important. I mean, everyone talks about Europe, and Europe certainly manage to get, the vaccines it needed. But let's keep in mind the majority of our member states are small or medium-sized. And if they had tried to purchase individually, rest assured, some of those markets would have been, very late in accessing the vaccines. They're simply so pooling together helped address this issue and certainly put all European countries in a stronger position. And we see that is also something which is increasingly felt in other parts of the world, and I think it's part of the solution. We saw initiatives like, apart from COVAX, of course, and I think there's a lot to be said about having a mechanism, if it's not completely permanent, maybe a mechanism that can be quickly brought into action as soon as needed. And then, of course, that could be linked with the pandemic treaty, for example. How do you create a mechanism that can be activated quickly, and how do you keep it functional if maybe in the interval between? But also there are other initiatives which we are supporting, like the African Vaccine Acquisition Task Team, AVAT, and others. And I think that's part of the answer. But ultimately, the bottom line is to really bring together supply, demand, and also regulation and health systems. These are the four corners. You need to have production of more vaccines and a more equitable distribution of production capacity. We cannot afford to put all our eggs in one basket. Now, the current system of vaccine production has served us well in peacetime because it has resulted in, cheaper vaccines and, economies of scale, etc. But when you have a crisis, as we saw when the pandemic hit India, for example, then obviously this is going to be a problem. So how do you reconcile manufacturing in different parts of the world? Not everyone will be able to produce at the cheapest possible price. So the world also and this may be something else for the pandemic treaty, how does the world pay that kind of premium, what I would call a health security premium, to cover differences in price that will inevitably ensue? And then we're working on actually working with regions like Africa that is, at the moment is very dependent on not just for vaccines, but practically everything else. And there are already initiatives going on and work happening in places like Rwanda, Ghana, Senegal, South Africa, and hopefully others very soon. And there is an increasing interest, but also to adapt technology. It's now possible to produce vaccines in a quicker way, using more flexible and mobile tools. You can maybe even start to think about technology that could be brought into an area and ramped up in production quickly. But all this has to be reconciled with the demand side, because if you're just producing vaccines, as we saw with the Aspen case, and then you don't have a market, and vaccine production and many other pharmaceutical production requires advanced planning. You need to know how many doses will be required, who will require them, what characteristics the product needs to have. Does it require ultra cold chain? Is it single dose, multi-dose? What is the frequency of the booster shots? If you don't have this information, industry cannot produce. So one value of joint procurement that we've learned in Europe is that apart from putting yourself in a stronger negotiating position, it also helps to build the global picture of what you'll require over the next 3, 6, 12 months, maybe even longer. And that really also is something. And then, of course, there's the regulatory side, because if you take a region like Africa, for example, with over 50 countries, now there is a very strong political leadership to have the African Medicines Agency, for example, up and running. We are strongly supporting that as well. The industry, if you force the industry to apply for authorization in 54 different countries, they will choose the markets that are of most interest. If there is one single authorization for the entire continent, then obviously that means that is a much more manageable prospect. That's what we do in Europe. So I think there are many lessons, and the key lesson learned is to bring all this together. It's not just about technology transfer. It's not just about supporting international instruments. It's bringing them together, making sure you can match supply, demand, and also other instruments. I mean, surveillance was mentioned. If I could just reply very quickly on that, because surveillance, of course, is not the answer to everything, but it is terribly important. Why? Because it's like the radar when you're flying an aircraft. If you don't know what's going on, for all we know, there might be something, right now incubating somewhere, and if you're unaware of it, and we saw what happened with COVID, the key maybe to preventing a lot of this would have been in the pre-pandemic phase. What was happening in China and in the end of 2019. That is key. Now, of course, surveillance, however, is an early warning system. It means you have to have then the mechanism to follow up. It's useless to pick up signals if you don't then have the means to intervene. But it is definitely important. It's a good place to start, but at the same time, then you need to make sure that once you have an indication that something is going on, and also to produce vaccines, you need to have the genetic material. So unless you know what you're targeting, you can't produce the vaccines. So surveillance is an important first step, but then on its own, of course, it's just the radar screen. I mean, if you see a collision coming, you have to have the mechanism to avert the collision.
Thanks, Martin. On that note, we've actually run out of time, and I want to say a big thank you to both our speakers online, to Gail and to FIFA, and then both in the room, to Inma and Martin. It was a really interesting conversation, and I think there's clearly many lessons that are being learned and still being learned, and that a lot has certainly changed in the past 2.5 years. But there's an acknowledgement that I think health is not only a national, regional, that it really is global, and that beefing up your own country's health system is also twinned with beefing up everyone's health security. Please stay tuned for the panel discussion, an interview with Chris Sturkens of Janssen, moderated by Helen Collis, after a short coffee break for those in the room. And thank you to those online. Thank you.
This is an age of disruption, of profound revolutionary change.
What we're really asking ministers is to empower the ambassadors.
The only thing that you really push forth is the truth.
You don't see many women represented when it comes to the decisions as to how to handle the pandemic.